Jugular vein thrombosis, JVT, is a relatively uncommon but clinically significant condition characterized by the formation of a blood clot, thrombus, in one of the jugular veins located in the neck. These veins, the internal, external, and anterior jugular veins, are responsible for draining deoxygenated blood from the brain, face, and neck back toward the heart. Thrombosis in this area can interfere with normal circulation, pose risks of clot migration, embolism, and signal underlying medical conditions. Although less common than thrombosis in the legs, deep vein thrombosis, DVT, JVT has gained attention due to its association with infections, malignancies, and the widespread use of central venous catheters. Causes and risk factors. Jugular vein thrombosis can result from multiple causes, often linked to Virchow's triad: endothelial injury, stasis of blood flow, and hypercoagulability. Medical procedures. Placement of central venous catheters or ports is the leading cause, especially in hospitalized patients. The catheter can irritate the vein wall and trigger clot formation. Hemodialysis catheters are also strongly associated with JVT. Infections. Lemierre's syndrome, a rare but serious infection caused by Fusobacterium necrophorum, can spread from a throat infection to the internal jugular vein, leading to septic thrombophlebitis. Other infections in the head and neck, such as tonsillitis or dental abscesses, may also trigger thrombosis. Malignancy. Cancers of the head, neck, or thorax can compress veins or cause a hypercoagulable state, predisposing patients to thrombosis. Hypercoagulable states. Genetic conditions such as factor V Leiden mutation, prothrombin gene mutation, or antiphospholipid syndrome. Acquired risks like pregnancy, oral contraceptives, hormone therapy, or prolonged immobility. Trauma and surgery. Neck trauma, surgical interventions, or radiation therapy can damage venous structures and increase risk. Symptoms and clinical presentation. The symptoms of jugular vein thrombosis can vary widely depending on the extent of the clot and whether it is complicated by infection. Neck pain and swelling, localized tenderness or swelling along the jugular vein is a common sign. Visible vein distension, in some cases, the vein may appear engorged or cord-like. Headache, due to impaired venous drainage from the brain. Dysphagia or difficulty swallowing, if the clot compresses nearby structures. Fever and sepsis, when associated with septic thrombophlebitis, example Lemierre's syndrome. Pulmonary embolism, PE, if the clot migrates to the lungs, it may cause chest pain, shortness of breath, or even life-threatening complications. It is worth noting that some patients remain asymptomatic, and the condition may only be discovered incidentally through imaging. Diagnosis. Prompt and accurate diagnosis of JVT is critical to prevent complications. Ultrasound with Doppler, the first-line diagnostic tool due to its non-invasive nature and high sensitivity in detecting thrombi. CT or MRI venography, provides detailed imaging of venous structures, especially useful when deeper veins are involved. Blood tests, D-dimer testing may be elevated, though it is nonspecific. Blood cultures are important in suspected septic thrombophlebitis. Complications. Jugular vein thrombosis can lead to several serious complications if not treated properly. Pulmonary embolism, a migrating clot may block pulmonary arteries. Septic emboli, in Lemierre's syndrome, infected clots may spread to the lungs or other organs. Cerebral venous hypertension, if venous outflow from the brain is obstructed. Post-thrombotic syndrome, chronic pain, swelling, or impaired venous drainage in the neck and head. Treatment. The management of jugular vein thrombosis depends on its cause and severity. Anticoagulation therapy. The mainstay treatment involves medications such as heparin, warfarin, or direct oral anticoagulants, DOACs. These help prevent clot progression and embolization. Duration of therapy usually ranges from 3 to 6 months, but may be longer in persistent risk cases. Antibiotics. Essential if infection is present, especially in Lemierre's syndrome. Broad-spectrum antibiotics are started and later tailored to culture results. Catheter removal. If a central venous catheter is the cause, it may need to be removed or replaced. Surgical intervention. Rarely necessary, but may be considered in abscess drainage or persistent septic thrombosis unresponsive to antibiotics. Prognosis. The prognosis of jugular vein thrombosis varies. With early diagnosis and treatment, most patients recover without severe complications. However, delays in recognition, particularly in septic thrombophlebitis, can be life-threatening. Mortality rates are higher when complicated by sepsis or pulmonary embolism, underscoring the importance of timely medical care. Conclusion. Jugular vein thrombosis is an uncommon but important vascular condition that requires a high index of suspicion, especially in patients with central venous catheters, head and neck infections, or underlying malignancies. Though its presentation may range from mild neck discomfort to life-threatening sepsis or pulmonary embolism, advances in imaging and treatment have improved outcomes significantly. A multidisciplinary approach involving internists, infectious disease specialists, and vascular surgeons ensures comprehensive care and reduces the risk of complications.